Thank you very much indeed, Ruth. And I had a dream. My dream was 2 days ago when I received a letter. And this is my response to that letter. The letter is addressed to the Department of Taoiseach Government Buildings, Upper Merrion Street, Dublin 2, from Highlands Hotel, dated the 24th of July, 2018. Dear Taoiseach, thank you for your letter asking me if there was anyone who can make the health service fit for purpose. By curious coincidence, I've been asked the same question here in Glenties. I hope you don't mind if I share some of my thoughts with them. Your question, from my interpretation, is about leadership and inevitably how it is bound up with your current master plan, namely Sláintecare. In responding, Taoiseach, I should say that it is not my intention to catalogue all the well-known woes of the health service, waiting lists, hospital trolleys, etc., and I bow to Susan Mitchell and her exemplary reporting on all those things. Or indeed, am I going to celebrate the many outstanding successes that we have manifest in our health service every day, and so recently exemplified by last week's RTE programme, My Broken Brain. However, judging by the predictions of the impressive 2017 ESI report, it seems pretty likely that costs are going to continue to soar and the health service might easily implode even before you retire from politics at the age of 51. You and I both know that things really do have to change radically, but as you know, fundamental change has a habit of happening very slowly here, or mostly not at all. And to steal my own words, by consistently poor politics, a faltering administration, and vested and professional interests. This is why your introduction of the Sláintecare concept must be regarded as such a great success, even though not perfect in design. First and foremost, it provides a long-term strategy that has cross-party agreement at last. Secondly, few would argue against trying to establish a universal single-tier health service, where patients are treated on the basis of health need rather than their ability to pay. Like Roisin Shortall, when it comes to health, we're all socialists until, of course, it comes to paying our health insurance premiums. And thirdly, we have created Sláintecare ourselves. Bravo. Nowadays, in our health service, we mostly try to solve our problems by hiring expensive, foreign, self-serving consultancy firm. This time, thanks to your good offices, Taoiseach, it is our own creation, and for me, that makes the prognosis much better. But it is my concerns that will underlie the themes of this letter. Let's start with governance. The history of the health service, Taoiseach, is strewn with failures to adopt so many world expert reports and plans that have withered on the vine. Portlaoise is a contemporary case in point. The enormous cost of implementing Sláintecare is not just the price we have to pay for the lack of resource and management over many years, but also what we need to pay for our future healthcare and for our children's. The long-awaited cross-party recognition of this reality was what created Sláintecare, but we wonder if this was a mirage when we see your government already stumbling at the first fences. Our health overspend is a persistent reality that arrives annually, as predictably as Ash Wednesday. If that is to be the recurring excuse for delay and prevarication, then this will simply add fire to those skeptics who wonder whether your government, any future government or cross-party agreement, will ever have the courage to implement Sláintecare. The risk can be summed up in 4 words: faint-heartedness, politics, labour, and by that I mean unions, laws and contracts, and funding, of course. Nevertheless, we welcome the appointment of Lori McGahy as the newly appointed Executive Director of Sláintecare, which brings us back to your original question, Taoiseach, about who's going to make the health service fit for purpose. It seems now that you have a full house of possibilities. Minister Harris, the Secretary of the Department of Health, Jim Breslin, Ms. McGahy, the soon-to-be-appointed Director General of the HSE, and 5, the soon-to-be-appointed chairman of the HSE, as well as the Director General, and 6, Tom Keane, who is to chair the Advisory Council. So, Taoiseach, with you included, we have a magnificent 7. But now we see the Sláinte Care Implementation Office will no longer be under the auspices of your office, Taoiseach, and should we be concerned that this is or might be an early indication of your disaffection? And then, where will the other cross-party constituents fit? And where will they be, or will they simply object to everything your government tries to do? So what do we mean by leadership? So, Taoiseach, instead of one, we now have 6 leaders, but are we sure their roles and responsibilities are clear and their boundaries defined? I'm not sure about that. If they are, then that's okay, because the concept of leadership has changed. Whereas it once was thought to be that getting the right leader in place would be enough to change the system, we know now that the model of heroic leader at the top of a pyramid rarely provides an answer. In the contemporary perception of cooperative leadership, which we hope we now have, the pyramid has flipped, with true leaders now seeing themselves at the bottom of the pyramid, serving the people who report to them by providing them with what they need and maximizing communications between them. Just as leadership is important, so also is followership, although in truth, in healthcare, each member of the workforce should be a leader, even those who don't consider themselves exceptional, but rather because they see what needs to be done and can work with others to do it. The health service is, by common consent, a large, poorly managed, complex organization that badly needs high-quality leadership, administration and management, working together if it is to transform. Addressing better pay and enhancing a standard and uniformity of training with perhaps a national leadership centre should be part of the solution, and it would likely provide a significant return on investment. Poor leadership and poor management, as we've seen too often, comes at an enormous cost. Of note, the words pay, remuneration and salary are not mentioned in this context in Sláinte Care. There is now an abundance of evidence that where engaged doctors and nurses and other professionals are provided with clear information about costs, along with the authority to tackle them, they will actually do so. We already have many committed clinicians, clinical directors, program leads, clinical managers, etc. But the net needs to widen. The learning of quality improvement as a subject should be developed across the continuum of medical training. Many contend that it is an important subject as anatomy and as skill as important as CPR. Ongoing quality improvement and patient safety is also a consistent distinguishing feature of the best hospitals and practices in the world. These are also characterized by frontline decision-making and by having long-serving leaders with managed transitions at the time of change to maintain strategic direction. We certainly don't do that here. The learning and the transfer of knowledge here too often stumbles on changes in personnel. Also, there is often a culture of not invented here. Health Improvement Scotland provides a good example of bringing together a national sharing and learning hub. Then there's the oft-used word accountability, and we heard a lot about that this morning, which really should come with responsibility. It is a word that's used extensively in the Sláinte Care document, but never defined, although it has now become synonymous with someone to blame when things go wrong. It is, in fact, I think, something completely different. In industry, it's axiomatic that one's job and performance is reviewed and appraised by one's line manager at regular intervals. I find it astonishing and extraordinary that in my 30 years of consultant practice, nobody ever looked at what I did or how I did it. And I believe this absence of reviews and appraisals is pervasive through the health system, whether clinical, managerial, or administrative. Perhaps a root cause to part of our problems. Only by regular reviews of this sort will we learn what people do and what people we need, and more importantly, what or who we can do without. Our inability to discipline and to hold poor practice to account is commonly far less to do with inadequate employment laws and much more to do with our failure to document performance or failures of management in the handling of disciplinary procedures. So what's important with regard to this word capacity? The Health Service Capacity Review 2018 Taoiseach highlights the extent of the demand pressures that are likely to be placed on the healthcare system over the next 15 years. It presents a view of how these demand pressures may translate into capacity requirements under our current model of care in a system that is already operating at or beyond capacity. It makes recommendations for substantial changes in hospital beds and in the delivery of primary and community care, and including residential and home care. Typically, they also recite the mantra, the need for health reform, better management, reconfiguration, and integration that we hear about all the time. But the review admitted to include an examination of staff resourcing for acute hospitals, interestingly enough. But the review had an international expert panel, and they were at pains to correctly point out that any recommendations on bed capacity without the hospital workforce element being looked at as well was a completely meaningless exercise. More importantly, they stressed the need not just to transform the acute sector, but to link it to primary, home, and long-term care beds, which are so relevant to making hospitals work. Moreover, the expert panel also stated that workforce planning is a key issue for the future, particularly to reverse the migration trends of our health staff. Sláinte Care also acknowledges the need to rectify the serious shortage of consultants, GPs, nurses, and other members of the workforce. Primacy must be given, however, to sorting out the contracts of newly appointed consultants and GPs once and for all, and to support the ICGB to train and recruit more GPs. Why is organising healthcare so important? The views, Taoiseach, of that Capacity Review's expert panel arise because over the years, our health silos have grown hand in hand with the huge expansion and growing capacity of healthcare. Silos have isolated managers, clinicians, specialties, clinical teams, and hospitals from one another, and more importantly, hospitals from primary and community care. This is not in the interest of patients and their ability to flow through the system. So far, we have only played lip service to integration and bringing together all these services and modalities of care. Our geography and our population demographics are partly to blame. I've previously stated that you can oil and rewind a clock all you like, but if the cogs don't fit, nothing will happen. The fit between the community healthcare organisations, their local health offices, and our hospital groups is an apt comparison. Happily, Sláinte Care recognises this. The hospital groups are a problem. Each is composed of a number of hospitals bundled together based on old or contrived university affiliations. In addition, the community healthcare organisations, of which there are 9, and hospital groups, of which there are 6, not including the children, they do not align numerically, administratively, or geographically. Contrast this with the southeast region of Wales, where Alison Williams is an award-winning CEO and is in charge of both the hospitals and also primary and community care services for the population in that region. Her budget is finite, and she has to manage patients in whatever is best for them and in the most cost-effective setting for her catchment. As a consequence, she does not, in her own words, focus just on hospital beds for patients, but she sees every resident's own bed in their own home as the best place for appropriate rest and recuperation, intermixed with proactive reablement in the community. That's what I call integration. If integration and better flow for patients is truly going to happen, this has to be resolved. My colleague Jerry Keller and I, with the benefit of population geolocation data and other data, can show that it is entirely feasible that there be 5 hospital groups, 5 community health organisations, merged as 5 healthcare networks, delivering a package of integrated preventative, primary, secondary and tertiary care that is logical, community-based, and largely defined by county boundaries. It just simply makes sense. Of course, this must and should not preclude the continuing development of academic health centres and their critical role in education and bench-to-bedside research, but that's a different exercise. And then there is a planned elective and private healthcare. Sláinte Care Committee have correctly emphasised the need to ring-fence elective beds. As a surgeon, I'm very happy to hear that, which is predominantly surgical, and to expand the practice of day surgery. It is also quite true, Taoiseach, that the growth of the two-tier system has been unfair. It wouldn't have happened without the mendacious political manipulations so correctly documented by Sarah Burke and Julian Mersel. But we are where we are. We now have 19 private hospitals. 43% of the population has private insurance. In 2015, private hospitals delivered approximately 15% of inpatient bed days and approximately 31% of day services. Nationally, 1.5 times the hips and knee replacements are performed in the private system rather than in the public. Yet private healthcare is usually ignored in health planning, even though it is a significant tributor. The Sláinte Care's sole contribution on private healthcare is to suggest that private patients simply be removed from public hospitals, taking €700 million with them, and using the vacancy to provide more capacity for public patients. As an advisor to the NTPF, one of my roles is to inspect private hospitals, and in the past 24 months I've visited all of them except one. They are mostly very good, and some excellent by any international benchmark, admittedly without having to face the tsunami of the injured, aged, and indigent of the public system. The reason for the high standard is largely due to accreditation. They are all accredited by an outside body, whereby their standards, performance, and behaviours are analysed in depth by a 4-day inspection every 3 years. Meanwhile, only 2 of our public hospitals have so far submitted to external accreditation. My prediction is that when the planned licensing of hospitals is finally introduced, HICA will have no difficulty with the private hospitals. Rather than therefore disassociating ourselves from the private and disassociating the private from the public system, I think a more mature approach should be taken to in some way embrace it, and I can develop that later if you want. Anyway, just as important, and most important still, is the business of separating acute from planned care. So finally, I want to just talk about the patient. So what about the patient in all this, the most important person, if you like? I've left this to last, Taoiseach, because I'm not now a professional, but I'm an elderly patient. Speaking for patients, we want Sláinte Care. We're tired of waiting. We desperately need a committed, more resolute, less convulsive government with greater honesty, less intrigue, and clearer governance and cross-party engagement, and a far better understanding of where we are and where we're actually going to. I believe that our views must be considered, that's patients, individually, but provided for communally, such that we are confident that the greatest good is being served, devoid of vested interest, and we must be part of that open debate on rationing, which is inevitable and in truth already with us. Finally, Taoiseach, as to who might really make a difference in making the health service fit for purpose, I'd be very happy to recommend Joe Mulholland, Ruth Barrington, Susan Mitchell, Colin Doherty, and Stephen Donnelly, although I suspect that Stephen Donnelly and his tribe might want to take over at some stage. I remain yours faithfully, Michel Amas,